Thanks so much for joining me for this presentation on interpreting hip surveillance x-rays with the HipScreen app, a primer for the radiology novice. My name is Vedant Kulkarni, and I'm a pediatric orthopedic surgeon at Shriners Hospitals for Children in Northern California. And the goal of this presentation is to give you the fundamentals of how to interpret an x-ray for hip surveillance in a child with cerebral palsy. I have no financial disclosures. Before we get started, it's really helpful to look at the HipScreen.org website, and particularly the tutorial section, because much of what I'm presenting today is available on that tutorial section as videos and other resources. The HipScreen app can be downloaded for free without any commercial content. And the HipScreen app doesn't transmit any of your data to any outside server. It's purely a community-based effort to try to increase the availability of hip surveillance to all children with cerebral palsy. Hip dysplasia and hip problems are very common in children with cerebral palsy. Up to 1 in 3 children with CP will develop hip displacement. Among those children with severe cerebral palsy, up to 1 in 5 will have a hip that completely dislocates from the socket. As you can see in this child, over 2 years, it goes from subtle hip displacement that you'll be able to better recognize by the end of this presentation to a painful dislocated hip with very poor options for treatment. 50% of these hips that are dislocated will become painful over time. And so hip displacement represents a huge burden of disease on a population of children with CP. The migration percentage obtained from an X-ray of the pelvis is the cornerstone to early identification. The migration percentage refers to the percentage of the ball that is not covered by the socket. And a migration percentage of greater than 30% has been shown in studies to increase the risk of progressive displacement, and is the trigger or threshold in most hip surveillance programs to send a child to a specialty center for closer monitoring and possible treatment. A hip surveillance program has been shown by this landmark study out of Sweden to prevent dislocation of the hip across the population of children when applied appropriately. And when I mean apply appropriately, that means that children get timely x-rays. The results of those x-rays are acted upon with the appropriate treatment that could involve preventative or reconstructive surgeries. And then that they're followed up very carefully. When that treatment protocol is used, hip surveillance programs can prevent dislocation, as you can see from this declining rate of hip dislocation in the population over the 20 years that hip surveillance was instituted. Hip surveillance is the standard of care for children with cerebral palsy, as established by studies out of Australia and Sweden. In California, hip surveillance has been established as the standard of care through the California Children's Services, and the American Academy of Cerebral Palsy and Developmental Medicine has released a care pathway for hip surveillance to make it the standard of care. But barriers to implementation exist. Some of the issues that people mention are that the guidelines are too complex. They don't know how to read an x-ray, and so then they can't really know when to send a child. Measuring x-rays takes too much of their time, and that even when they send them, the patients to x-rays, the reports from the radiologists don't measure the migration percentage. Well, it's to address some of these barriers to implementation that the HipScreen app was developed, and its companion website, hipscreen.org. So I recommend that you download it for free to your device through the Apple App Store or Google Play. The HipScreen app has educational material in a PDF format that can be easily shared, including why do hip surveillance, the interpretation of hip surveillance x-rays, similar to the format of this presentation, but now in a PDF form. There's a protocol, radiology protocol, that can be sent to a radiology suite so that the child is positioned properly and that the proper measurements are made by the radiologist. Within the app, there's a description of the level of functions through the gross motor classification system, and full text surveillance guidelines using the CP Academy guidelines. Australia, Sweden, and British Columbia are available through the app for free. In addition, full text CP classification systems are also available. The second tab on the main menu allows you to simplify the interpretation of the hip surveillance guidelines. So you simply touch the patient's functional level, and then the hip surveillance guideline will pop up. That is the CP Academy guideline, telling you when to obtain pelvis x-rays and when to do clinical exams. In addition, when to refer to orthopedic surgery. Finally, the most novel aspect of the tool is the ability to take a picture of an x-ray, whether it be on a computer screen or even a piece of paper, and then easily measure the migration percentage on the device. Now, I should say the HipScreen app does not store any of the photos that you take within the app to your device, and it does not transmit any of the photos that are taken within the app to any third party or any other server. Now, if you already have a photo on your device, you can upload it to the HipScreen app, but it doesn't change or modify it in any way. It's important to keep in mind that you should follow the privacy laws of your country and not photograph any patient identifiable information on any personal devices. But these features that were built into HipScreen to help with the privacy protection can help allay some of the fears. Let's get into the majority of the talk. I want to guide you through learning the language of radiology, because it is like a foreign language, and better understand all of the landmarks that you might see on an x-ray so that you can speak the same language as the radiologist and as your orthopedic surgeons, and be in a better position to make measurements on your own. First of all, let's talk about orientation. We need to be speaking the same language. And so an AP pelvis x-ray is an x-ray that obtains both hips in a single x-ray plate, as you can see here. And that image is represented to us as if we're looking at the child. So the right hip is labeled and the left hip is labeled here. Notice that the left hip is to our right. Now don't let that fool you, because whenever I mention left hip, I'm always referring to the hip as in reference to the child. Here are some of the important radiographic landmarks on an AP pelvis x-ray. Then we'll get into more of these details as we go through the subsequent slides. The first is the femoral head ossific nucleus. Here outlined with the black dotted lines. This is the ball of the ball and socket joint. And the dotted white lines here outline the remainder of the femur. The two red arrows are the inner and outermost margins of the femoral head ossific nucleus. And these are important landmarks for the measurement of migration percentage. The acetabulum is the socket of the hip ball and socket joint and is outlined here with the black arrows. This red arrow points to the outermost margin of the acetabulum, and this is another important landmark for the measurement of migration percentage. The part of the acetabulum that supports the body weight develops into a thin white line called the sourcile, and the acetabular sourcile is outlined with these black arrows. Sourcile means eyebrow in French, and so you can help you remember the ideal shape of this radiographic landmark using this information. The acetabular teardrop is outlined with these dotted lines, and the innermost border is the border of the acetabulum. The red arrow here shows the bottommost portion of the teardrop, which is a reliable landmark to help measure the migration percentage. Children's hips are growing from growth centers made from cartilage, and the triradiate cartilage is the center of the hip socket and appears as this dark line outlined here with the arrows. The red arrow shows the outermost margin of the triradiate cartilage, which is another important landmark for measuring migration percentage. The pelvis has two other important landmarks, the pelvic wings and the ischial tuberosities, both of which are labeled here. The red arrows mark the uppermost margin of the pelvic wings and the lowermost margins of the ischial tuberosities, which can be used as landmarks for the measurement of migration percentage. Finally, it's important to have a language for discussing direction on an X-ray. We use the term medial to mean towards the center of the child's body, and the term lateral to mean towards either side of the child's body. You'll notice that medial and lateral are relative terms, as you can see labeled here in this blow-up of the patient's left hip. So that the lateral extent of the triradiate cartilage is medial to the medial edge of the femoral ossific nucleus. This relative terminology becomes important when we're starting to use some of the landmarks for measuring the migration percentage. So let's get into it. Now that we've gone over the language of radiology, we can now begin starting to calculate the migration percentage. Again, the migration percentage is the cornerstone to early identification. And this is how it's obtained. The child is laid on the cassette, on an X-ray cassette, and the X-ray beam goes from anterior to posterior. So it's called an anterior-posterior pelvis X-ray, or AP pelvis X-ray. The first step to calculate migration percentage is to confirm that you have a properly positioned AP pelvis X-ray. For proper positioning, the child should be positioned with the pelvis horizontal, the legs in a neutral position, that is not spread apart, but straight down from the pelvis. The patella should be also pointing straight forward. It's important that if the child has a hip flexion contracture, that pillows are placed under the legs so that the pelvis points straight forward. Here are some of the features of an appropriately positioned AP pelvis X-ray. There should be symmetric pelvic wings, a hip and femur that's held in neutral abduction or adduction, and symmetric and oval obturator foramina. The pelvis on the far left has all of these features. The pelvis in the middle has been rotated so that the pelvic wings are asymmetric and the obturator foramina are also asymmetric. In addition, in this middle X-ray, notice that both of the femur bones are abducted or spread away from the body. The pelvis on the far right has been tilted forward, such as in a child with a hip flexion contracture, without positioning pillows under the legs. This has created a view that shows the pelvic inlet very well, but notice that the hip landmarks are poorly seen. And also, notice that the obturator foramina are not oval and are hard to see. This is one of the tip-offs that the child has hip flexion contractures that were not properly accommodated for. Step 2 is to establish the horizontal axis of the pelvis. Since not all children are placed exactly straight on the X-ray when it's taken, it's important to draw the horizontal or H-line as a reference for our measurements. This can be done by connecting the triradiate cartilage of both hips, outlined here in red. The triradiate cartilage is closest to the center of the hip joint and is the most accurate of all of the measurements for the H-line. If the triradiate cartilage is not present, that is, a child is older and they're fused, or if it's not entirely visible, the acetabular teardrop is your next best choice, here outlined in green. If that's not possible, either the ischial tuberosities, outlined in orange, or the iliac crests, outlined in blue, can be used. The closer the H-line is to the center of the hips, the more accurate the leveling will be. And so I would recommend using the triradiate cartilage if possible. The third step is to draw 3 perpendicular lines to the H line. The first line is the M line, the most medial line, and that should touch the innermost or the medialmost border of the femoral head ossific nucleus. The second line is the P line, the red line, which should intersect the lateralmost edge of the acetabulum. The L line is the lateralmost line, here seen in white, and should intersect the edge, the lateral edge of the femoral head ossific nucleus. Now, to calculate the migration percentage, it's simply measuring the distances. It's distance A over distance B for each hip, which is the percent of the femoral head ossific nucleus that lies outside of the lateral edge of the acetabulum. Remember again, a migration percentage of 30% correlates to progressive displacement over time. And because this displacement can be silent, when caught early and the child is referred early, it can lead to better outcomes. Let's talk about ways that reliability can be improved by better understanding some of the more subtle features of X-rays. When establishing your horizontal line, it can be easy to do when the triradiate cartilage is nicely visible, like on this example on the left. But notice that on the example of the right, the features of the triradiate cartilage are a little bit more obscure. And so you can do your best guess to establish a horizontal line, but use another pelvic landmark to double check your H line. In this case, I use the ischial tuberosities. You could also use the acetabular teardrop. In this particular image, the iliac crests are obscured. And so using either the acetabular teardrop or the ischial tuberosity will be good double check lines. Another trick in hard to identify triradiate cartilage is to use your sourceal to help find the edge of the triradiate. I'm going to outline the sourceal here in blue, and it meets the triradiate cartilage here at this point. And so that can be used as your point to draw your horizontal line. Let's now move to some of the landmarks of the femoral head. It's very important to use the femoral head ossific nucleus and not the neck of the femur for the M and L lines. The femoral head ossific nucleus borders have been shown here by the orange arrows, and the neck borders have been shown with the black arrows. And so the ideal measurement should use the solid white and the solid black lines as the lateral and medial border of the femoral head. And this is what we use to assess migration percentage and not the femoral neck. Now let's move to some of the variability that's seen in the acetabulum. As you can see from these 4 examples, there's a tremendous amount of variability in the morphology of the lateral edge of the acetabulum. Before we jump into an algorithm to help standardize the measurement of the lateral edge of the acetabulum, let's review the landmarks again. The sourceal is the radiodense white line of bone that extends from the triradiate cartilage all the way to the edge, to the bony edge of the acetabulum. Now, in some cases, this can have a Gothic arch appearance as seen on the left. That means that the femoral head, that the acetabular sourceal goes up and then comes down. That looks a lot like a Gothic arch of a church, and so it's given this name Gothic arch. In the normal example, you can see that the acetabular sourceal goes up and then comes back down in a smooth manner all the way to the edge of the acetabulum. The bony edge of the lateral acetabulum is shown here with the red arrow. It goes just before the upturn of the ilium. So using this terminology, let's go through an algorithm that we published recently on how to accurately identify the lateral acetabular edge. We have to ask ourselves a series of questions, and I'll lead you through those questions through 4 examples. So in this example, we have these two x-rays. They're actually the same x-ray, but the x-ray on the bottom has a crosshair where the center of the crosshair correlates to the edge of the acetabulum that should be chosen. The top x-ray shows you without any markings so that you can see the landmarks a little bit better. So in this example, you can see that the acetabular sourcile can be seen all the way to the edge of the acetabulum. And there's no Gothic arch present. It doesn't go up and then come back down. It's a smooth contour. And so the answer to the first question is yes. And is a Gothic arch clearly visible? No. And so we're going to use this lateral edge of the acetabulum that I show with the laser pointer here. And on the image below, I'm showing with the crosshairs. In this second example, we do see an acetabular sourcile that goes all the way from the triradiate cartilage all the way to the edge of the acetabulum. But importantly, a Gothic arch is visible because we can see how it upturns right in this area. When that's the case, we're going to use the apex of the Gothic arch, the highest point, to be our edge of the acetabulum. And you can see that here with the laser pointer and with the crosshairs on the image below. The idea here is that likely there's some rotation of the pelvis so that the socket is being seen out of plane, and that apex of the Gothic arch represents the true edge of the socket. Let's move to this next example. Here, there's a little hint that there might be a sourcile, but that there might be a Gothic arch, but notice that the sourcile is not clearly visible in this area. And so it's really unfair to, and not reliable to use the apex of a Gothic arch because the sourcile is not clearly visible. So because it's not clearly visible, we are able to identify a lateral acetabular edge, and so we're going to use the bony edge of the lateral acetabulum, shown here with the laser pointer and shown below with the crosshairs. And in this final case, the sourcile is clearly not seen, and the lateral acetabular edge, it's hard to determine, is it here, is it here, is it here? Well, we're going to use the furthest lateral point that we can using our clinical judgment, as shown with the laser pointer here on the image above and with the crosshairs below. Using this algorithm, we can improve our accuracy of measurement of the lateral acetabulum despite the variability. Now, I'd like to go through some of the methods of measuring the migration percentage. The first method is the digital measurement method on a PACS workstation. And here you have to measure distances, drawing vertical lines to arrive at the final measurement. This can be a little bit cumbersome. It does require digital measurement of accessibility and understanding and experience with this technique. Now, if you have it on a piece of paper, you would have to use a ruler and a pencil to do the same thing. If you happen to be at an institution that has a computer-aided digital templating system, you can use this pre-made tool to move vertical lines, and then it'll automatically calculate the migration percentage without having to actually measure distances. So that saves some measurement technique challenges. Now, I'd like to go through the HipScreen method of measurement. And what's different about the HipScreen measurement is that we don't move any lines on the screen. We are rotating, panning, and zooming the image to fit to the ruler. And that allows us to adapt this method of measurement to a smaller screen with accuracy. So let's go through that real quickly. We select the camera, we take a photo of the image, and then, now this is a little bit on warp speed, so we use count CW and CCW to level the image, and then we can zoom in. We place the femoral head on the appropriate half of the ruler, which allows us to make an on-screen measurement without any measurement of distance, and we can use the other half of the ruler for the other hip and make an on-screen measurement. Using this technique, we've published that the migration percentage measurement with HipScreen is as accurate as computer-aided or manual digital measurement with an error in the range of 2.8 to 3.6 degrees. And that the reliability is excellent and is really equivalent to the other measurement methods. Importantly, it's significantly faster than manual measurement and clinically equivalent to commercially available computer templating methods, and it's completely free with no commercial content. Let's go through the details of measuring migration percentage using HipScreen. The first step is uploading a photo, and you can take a photo with the HipScreen app using by touching this photo icon, and then the program will then ask you if it's okay to access your camera. I assure you that it is not spying on you. It's really allowing you to take a picture with the camera through the HipScreen app. And like I said, it doesn't save or store any of the images that you take with the camera through the app. Now, if you happen to have a photo of an X-ray already loaded onto your device, it can bring that into the HipScreen app and it won't modify it in any way, but allows you to make the measurement on that photo. So those are the two methods that you can bring images into the HipScreen app to analyze. Once you have the image into the HipScreen app, you then press the rotate button here. And you can then pan and zoom the image so that you can better see the landmarks. And then you're going to use these two buttons, the CCW and the CW button, to rotate the image to appropriately place it and have it appropriately placed on the triradiate cartilage so that the pelvis is leveled. The triradiate cartilage, as I mentioned, is your first choice, but you can also use the ischial tuberosity, acetabular teardrops, or iliac crest. Now, because the pelvis is now leveled in the horizontal plane, we can now apply a ruler and then automatically make the measurements directly off of the screen without moving lines. And so I'll show you how to do that. The next step is pressing done, and then it goes back to this main menu and you press ruler. And that shows you this ruler on the screen. Now you would use the right half of the ruler for the left hip. Let me say that again. For the patient's left hip, you use the right half of the ruler. And for the patient's right hip, you use the left half of the ruler. That's because the child's, it's as if we're looking at the child. So half of the ruler is used for half of the X-ray. You then pan and zoom the image of each hip until the until the lateral aspect of the femoral head ossific nucleus touches the white line. The medial aspect of the femoral head ossific nucleus touches the black line. And now the femoral head is divided into 10% increments, with the red line at 30%. Now these numbers won't show up on the HipScreen app, but it's easy to make the measurements. And essentially all you do, this is your 0 line here, you can just count 10, 20, 30, 40. It's that 40% line that intersects the lateral edge of the acetabulum, indicating that 40% of the femoral head is outside of the lateral edge of the acetabulum. The migration percentage is 40%. Now, it's a little bit easier than that too. Now, if you don't want to actually measure the migration percentage and you just want to know, is this patient at high risk or low risk for progressive displacement, you have to appropriately place the hip on the appropriate part of the ruler. And then if the edge of the femoral head, if the edge of the acetabulum is inside this red box, on either hip, the migration percentage is over 30%. If it's outside of the red box, the migration percentage is under 30%. So this is an easy screening method to determine whether the child has met the threshold for referral. Let's go through some examples here. The image above shows a yellow arrow at the edge of the acetabulum without the ruler overlay, and the image on the bottom shows you with the ruler overlay. So here you can see that the edge of the acetabulum is between the 10 and the 20% vertical lines, so that's a 15% migration percentage. On this one, the migration percentage is 30% because the lateral edge of the acetabulum intersects the red line. In this example, the lateral edge of the acetabulum intersects the 10, 20, 30, 40, 50% line. So the migration percentage is 50%. And now it's your turn. This is the more exciting part of the tutorial, where you get to use your HipScreen app to actually do the measurements. And the way this will work is you'll use the HipScreen app, take a picture of the X-ray that I show you, and then afterwards I'll go through it in a live video about how I would measure it, and I'll give you some suggested answers. Now, the goal of this exercise is not to arrive at a quote-unquote correct migration percentage. The goal is to help you better understand how to use the HipScreen tool so that you can better measure migration percentage in your practice. There will always be discussion among experts as to what constitutes the lateral edge on this X-ray or what constitutes the femoral head ossific nucleus on this X-ray. So we'll try to liberate ourselves from some of that discussion and focus more on the tool. Let's go through the X-rays now. Here's X-ray number 1. So go ahead and open up the HipScreen app. And on the main page, select the migration percentage ruler. And then if it's your first time, there might be some boxes that pop up that you'll have to give permission to access your camera. And go ahead and give permission. And then in a horizontal format, in a landscape format, go ahead and take the picture. And that's key. The landscape format really allows you to get the full AP pelvis visualized and makes it easiest for the analysis. So you would press the camera icon and take a picture and then say use the photo. And then now the X-ray is loaded onto HipScreen. And go ahead and go through the analysis, and you can write down the migration percentage that you thought. And once you do that, then you can resume this slideshow, and then we'll go through me doing it live through a video. So here's the live version of it. Okay, so we're going to do it in real time. So we'll choose migration percentage ruler. Press the camera button. And now I'm holding it in horizontal mode, landscape mode. I'll go ahead and take a picture now. And I'll say use photo. And now it loads it onto the screen. I'll press rotate. And that opens up this next menu. CCW is counterclockwise, CW is clockwise. I'll level the pelvis through the triradic cartilage and then press done. The next step is to press the ruler button and now expand the femoral head to be on the appropriate side of the ruler with the left, the left-sided ruler being used for the right hip here. And then on the opposite side, we can go and use the ruler and expand the femoral head so that we have it appropriately placed. And we can write down the migration percentage measurements. And so the migration percentage measurement on the patient's right hip I measured at about 75%. And on the left hip, it was somewhere between the third and the fourth vertical. So I thought it was, I thought I could get to the accuracy of 33%. That might be a bit of hubris, but certainly slightly greater than 30%. Maybe we could say 35 if it lies between the two lines. So we'll go through the same sequence for each of the x-rays. And so here's x-ray 2. Go ahead and go through the sequence of measuring it. And then you can pause the presentation here, write down your measurements, and then resume the presentation so that you can see the live video. And we'll do this for the up to the 5th x-ray. So here we go. We're going to measure the migration percentage. And I'll show you a little trick on this version of the measurement that can be quite helpful. So again, use the camera icon, take this picture, use this photo. We'll zoom in so we can see the triradiate cartilage, press rotate. Use the appropriate tools. We can pan and zoom even in this mode, so feel free to do that. Then press done when we're ready. And now start the ruler. The white line touches the lateral aspect of the femoral head. The black line touches the medial aspect of the femoral head. And here what we're going to do is we're going to turn the ruler on and off. That on and off can actually help you better see the x-ray and make sure that you agree with the landmarks that you're using. And we'll go to the other side and do the same technique of turning the screen on and off, or the ruler on and off. So a suggested answer here that the migration percentage on the right is around 50%, and the migration percentage on the left is in the range of about 30%. And so of course that depends on how you're zooming and where you're placing it, but certainly, especially due to the displacement on the right side, this patient would need a referral to a specialty center for closer monitoring. Let's continue the process with x-ray number 3. You can pause the presentation and then resume it when you're ready to see the live video. Let's go through the live video now. We'll use migration percentage ruler, engage the video, take our photo. We'll use this photo, then zoom in, press rotate, appropriately rotate the image, press done, engage the ruler, zoom in, place it appropriately. We're going to turn the ruler on and off to determine the to determine that the landmarks are appropriately placed on the ruler. And then we'll do the measurement on the other side as well. Here, the medial aspect of the femoral head is a little bit obscured, and so turning this on and off really helps the ruler function. And so the x-ray on the right was close to about 20%, and the x-ray on the left was about 35% by my estimates. Let's move to x-ray number 4. Go ahead and pause the presentation. Take the picture, and do your measurement. And then when you're ready, resume the presentation and I'll show it to you live. Here's the live presentation. So we press migration percentage ruler, take our picture, use this photo, zoom in. Here the triradiate cartilage is a little bit obscure, but I'm going to make my best attempt to try to level it. This is an example where I could use other measurements or other landmarks to make sure that I'm horizontal. I'm going to engage the ruler. We'll toggle it on and off because the landmarks are a little bit more obscure due to the quality of this X-ray. But once we're in a location that we're pretty confident with, we'll toggle the ruler button on and off and make additional adjustments as needed. And then I'll write down my suggested migration percentage measurement. And then I can move to the opposite hip and repeat the same process. Zooming in and then toggling back and forth to make sure that I can find all the landmarks. Here it was a little bit obscured medially, so I'm toggling on and off a little bit more. And on the right side, I thought that the lateral edge of the acetabulum was between the 3rd and 4th from the edge of the screen, vertical line, so around 35%. And on the left hip, it was closer to 25%, somewhere between the 2nd and 3rd from vertical lines. Okay, this is going to be our final example where there is a live video. And then after this, I'll just show you the X-ray and then the answer. So go ahead, pause it, and do your measurement. I'll give you a hint. This patient does appear to have a Gothic arch appearance to the acetabulum. All right, let's do the live video version. You'll see me starting the migration percentage ruler and taking a picture, rotating it before I even actually take the picture. That can help save some time. That way, there's less rotation when you're in the app. Press the rotate button. Make sure that I like it, the horizontal nature. And then now we're going to zoom in, turn on the ruler, and make sure that we have the landmarks appropriately placed on the ruler, with the white line touching the lateral edge of the the lateral edge of the ossific nucleus, the black line touching the medial aspect of the femoral head ossific nucleus, and then assessing which line touches the lateral aspect of the acetabulum. We'll do the same on the patient's left hip. White lateral, black medial, and then assess which line touches the lateral aspect of the acetabulum. And we can do a little bit of toggling to make sure we like our landmarks. Now in this case, the patient does appear to have a Gothic arch appearance to the sourceal with an upturning and then a downturning. And I've labeled here what I thought was the the apex of the Gothic arch. And on the right side, that is a 90% migration percentage, and on the left side, a 40%. Now notice that on the right side, if you just use the bony edge of the acetabulum before it starts to go up towards the ilium, that would be this area right here. Right here. And that still deserves a referral to a pediatric orthopedic surgeon, because the migration percentage here is 30, 40, 50, 60, 65, or maybe even 70, depending on what you use as your landmark. Now it's not 90, but that still is a very elevated migration percentage. On the left side, using the bony edge of the acetabulum would put you close to about 30%, which still deserves a referral. So as you can see, the Gothic arch may not really change whether a child gets referred or not, but in some cases it could. And so it's important to be aware of that appearance to the hips. The next 5 examples, I'm going to just breeze through with showing you the X-ray and then showing you the answer. And I'll leave it to you to take the time to do the measurements. So here's image 6 and the suggested answers to image 6. X-ray 7 and the suggested answers to X-ray 7. I have to make a little disclaimer. I think I might be getting a little ambitious with my assessments, getting down to single-digit degrees. It's probably more accurate to stick to about 5 degrees, but we can try. Here's image number 8. And the suggested answers to image 8. X-ray number 9. And the answers to X-ray number 9. And finally, X-ray number 10. And the answers to X-ray number 10. I hope that this presentation has given you some flavor of the HipScreen app and its utility for community-based hip surveillance in children with CP. I really encourage you to go to the tutorial section of the website here. And on that tutorial section will be a copy of presentations similar to this one. There will be PDFs of useful resources, a quick guide to help you quickly understand how to use the HipScreen app, and then also X-rays that you can use to test your ability to make measurements. So I hope that you found this presentation useful. I hope that you'll share it with your colleagues. We think that the HipScreen app could be used by parents as well to better understand the process of hip surveillance. And we think it allows everyone to engage in this important process of hip surveillance that has been shown to be so helpful and so impactful for children with cerebral palsy. Thank you very much for your attention.